Chapter 40 and 41, Respiratory Agents. We're going to first start out with drugs that affect the upper airway. When we talk about the upper airway, we're talking about the mouth, nose, pharynx, larynx, trachea, the beginning of the bronchial tree. Basically the part of the airway that brings in the air but doesn't actually get into the lungs where we will do the exchange. The most common conditions of the upper airway are going to be the common cold, allergies, sinusitis, laryngitis, and influenza. The most common upper respiratory infection is the common cold. It happens to adults about 2 to 4 times a year, and for children up to 12 times a year. Most of the time it is seasonal and happens in the fall and the winter. When you have the common cold, you will have nasal congestion, mucus secretions, a runny nose, or rhinorrhea, and a cough. It is a very large industry, especially for over-the-counter medications. You could also get acute rhinitis. Acute rhinitis can be related to allergies or an acute inflammation that comes with the common cold. And you can also get acute pharyngitis or acute laryngitis. Our first type of drugs that we're going to talk about are antihistamines. Antihistamines are used to prevent the histamine release when we are coming in contact with an antibody that triggers our immune system. They're often used for allergic rhinitis or allergies, as well as the common cold. There's a first generation and a second generation of antihistamines. The first generation has a lot of anticholinergic properties, as well as a lot more adverse effects. Specifically, the first generations have a lot of sedating effects. The second generation have minimal sedation effects, as well as they have less anticholinergic side effects. Our prototype for our antihistamine it's the first generation is the diphenyladramine or Benadryl. It is used as an allergic rhinitis and itching. It is also used to prevent motion sickness. It is used to help as a sleep aid, and it's also used for its anticholinergic effect, which would cause the urinary retention. And the whole concept of how it works is it blocks your histamines. It's contraindicated with anyone who has a lower respiratory disease, any type of significant liver disease, as well as if they're having an acute asthma attack. You want to be cautious with someone who has pre-existing urinary retention, BPH or benign prostate hypertrophy, as well as glaucoma. It also has an effect on other CNS depressants. So if you're taking other CNS depressants, you need to be cautious with Benadryl because of the fact that it will increase the sedation property. Your adverse and side effects, your life-threatening, are going to be hemolytic anemia, agranulocytosis, and thrombocytopenia. But those are extremely rare. However, your most common adverse effects are going to be your anticholinergic effects. Remember, your anticholinergic effects are you can't see, you can't pee, you can't poop, and you can't spit. It also has drowsiness and sedation. It can cause some hypotension, and it does cause mild photosensitivity And sometimes it causes a paradoxical response in children. And when it has that paradoxical response in children, it causes excitement. You also want to monitor whether or not you have that same paradoxical response if you're going to take it as a sleep aid before you actually need it. Because the worst thing is if you're going to be working a night shift and you choose to take Benadryl as a sleep aid, and you take it after your first night shift thinking, okay, I got to get a good, 6 to 8 hours of sleep before I go to work again the next morning. You take it for the first time as a sleep aid, and the next thing you know, you have the paradoxical response, and you're sitting there and you're just staring and you're anxious and you're restless and you can't get any sleep. For nursing implications and patient teaching, you always want to get baseline vital signs. You want to determine if there's any urinary dysfunction. You want to assess the cardiac and respiratory status, especially if they have a lower respiratory infection. You want to assess for allergies to the medication as well as environment. You want to assess sedation levels. If the patient has some gastric distress, they can take it with a small amount of food. If you're giving it IM for an acute allergic response, you want to do it in a large muscle. And you also want to monitor for your anticholinergic effects, especially in the elderly. You want to warn the patient about sedation and that they need to be careful when they take it and prevent falls. They need to minimize other CNS depressants, especially alcohol. And if they're taking it for prophylaxis, such as they're going to their Aunt Susie's house, and Aunt Susie has 12 cats, and you're highly allergic to cats, you're going to take your Benadryl about 30 minutes prior to going to Aunt Susie's so you don't have the allergic reaction. And you want to give them hints to help with the dry mouth, which would be increasing fluids, chewing on gum, having ice chips, and something like that to prevent that dry mouth. You have your second generation antihistamines. That is going to be your fexofenadine or Allegra. It is also used for seasonal allergies, allergic conjunctivitis, uncomplicated urticaria, so hives, and angioedema. And it too blocks the histamine response, but it has less sedation properties. You're only contraindicated for children and during pregnancy, and you want to be cautious with your renal patients. Adverse and side effects. You do have the potential for some dysrhythmias, and you still have some anticholinergic, but primarily the only anticholinergic effect that you have will be the dry mouth. It is also less sedating, so it's easier to take. So it's better to take this second generation if you have significant sedation with Benadryl and you're using it to treat allergies. Implication on patient education. You want to assess for renal status, especially patients who take it long term. You want to monitor your elderly. You do not want to administer it with grapefruit juice, orange juice, or apple juice because the fact that it potentiates the medication and makes the sedation worse. You want to monitor sedation and safety. You want to assess the lung sounds to make sure that you're not accumulating secretions and causing an infection in your lower respiratory tract. And if you have to do any skin testing, you want to make sure you stop all antihistamines 4 days prior to taking the tests. You want to advise the patient that there is potential for sedation, even though it is less than Benadryl. You want to make sure that they are not taking other CNS drugs because of the risk for increased sedation. You want to encourage them to drink lots of fluid, use humidifiers, chew on gum if they have the anticholinergic dry mouth, and just to monitor their symptoms to ensure that they are getting better. Our next category is our decongestants. Our decongestants help decrease the feeling of fullness in our sinuses when you are having upper respiratory infection. Our prototype drug is pseudoephedrine or Sudafed. It does have potential for abuse, and that is because in large dosages it can get broken down and created into methamphetamines. About 10 years ago, in 2006, they did create an act that limits and regulates the sale of pseudoephedrine and ephedrine because of the risk for the transferring of that into a controlled substance for methamphetamines. The most common over-the-counter medication is Sudafed, and it's regulated by going to the pharmacy. You can only buy 2 packets per pharmacy, and they document it by taking your driver's license and documenting that you are taking it and not stockpiling it. It is used because it dilates the nasal blood vessels when they become vasoconstricted, which causes that fullness feeling during an allergy attack, inflammation, or infection. If you take it for too long, you can have rebound congestion, and you do have local as well as systemic decongestants. So Sudafed's pharmacotherapeutics is for nasal congestions and relief of pressure of the otitis media, because the otitis media, the inner ear, the middle ear, is connected to your sinuses. So if you have a lot of pressure in your ears, you can take something, a decongestant, and it helps open up and alleviate that pressure. It's contraindicated for anyone who has severe hypertension or severe coronary artery disease. You want to be cautious with your diabetics, patients who have BPH, as well as increased interocular pressure. Your most common adverse effect is restlessness, tremors, jitteriness, insomnia, weakness, and your most serious one is going to be elevated blood glucose and hypertension and tachycardia. It actually is not recommended for patients who do have hypertension because it will cause an increased blood pressure and tachycardia, and it kind of causes that restlessness because of that tachycardia and the elevated hypertension. You want to, for nursing implications, you want to assess the respiratory system, blood pressure, and pulse to make sure that blood pressure is under control. It should only be used as a short term, up to about 7 to 10 days, because of the risk for rebound congestion. And you want to make sure that you're looking into safety measures. You want to make sure that you contact the doctor after 4 to 7 days if you're not showing improvement. And you should be increasing your fluids to help loosen up all the extra secretions that might be happening. And you want to use a humidifier, avoid smoke-filled rooms, and people who are sick. Your next drug is your intranasal glucocorticosteroids. So it's an inhaled steroid. Intranasal steroid. And that's going to be your fluconazole or Flonase. It's used to treat allergic rhinitis. It's anti-inflammatory. It's often used with other antihistamines. And if you use it too often, it will cause a dry nasal mucosa, which can lead to bleeding. Sometimes you will have a systemic effect, and that's primarily from intranasal dexamethasone, but Flonase does not cause systemic effects, and it should only be used on a regular basis for up to 30 days. Your adverse effects are going to be drying of the nasal mucosa, some burning and itching, but in general, it doesn't have many adverse effects. Your next one is your antitussives or cough suppressants. Antitussives used to suppress your natural cough reflex, which is a natural mechanism of protection, because when we swallow wrong or we drink something that goes down the wrong tube, we naturally start coughing it up so that it doesn't go down into our lungs and potentially create an infection. So therefore, it is a natural mechanism to protect. It is a good thing to have. However, there are at times when you do not want to have when you don't want to have a lot of coughing. A patient who just had a big, huge abdominal surgery or a big, huge back surgery doesn't necessarily, or even open heart surgery, doesn't necessarily want to be coughing a whole lot, because as you coughing, especially for that abdominal surgery, as you cough, you're creating pressure in your insides, and when you create pressure in your inner abdominal cavity, you potentially can do harm to the surgery you just had. Antitussives are available in liquids, syrups, chewable capsules, lozenges, and then you have a non-narcotic type, which you can get over the counter, narcotic, or a combination of a non-narcotic and a narcotic, which are both require prescriptions. The pharmacotherapeutics is to suppress a non-productive cough. And that's the key word, non-productive. If you have a productive cough, you want to get that junk out of your lungs. But if it's a non-productive cough, it's not really doing anything for you. So it's used for a non-productive cough. They're as effective as your opioid cough suppressants with a lot less adverse effects. Your prototype is going to be dextromethorphan, hydrobromide, or Benylin or Desalin. It is used for your cough. It is contraindicated with anyone who has a productive cough, children less than 2 years old, as well as coughs from emphysema or asthma. You need to be cautious with your liver patients and pregnant patients. You have an increased risk for toxicity with grapefruit juice, antidepressants, opioids, sedatives, and alcohol. Your most serious adverse reaction are hallucinations, but your most common is dizziness, irritability, nausea, vomiting, and some little bit of drowsiness. Other than the taste, they are handled quite well. Potential for abuse. The potential for abuse comes when you drink liquid antitussives at high dosages. You do have behavioral effects, which we call robotripping, or you're tripping on your Robitussin. And it does cause a stimulation or a euphoria. Normal adult dosing is from 10 to 20 milligrams every 4 hours, or 30 milligrams every 6 to 8 hours. It does have the potential for abuse, because if you're taking high dosages all the way up to like 500 to 1500 milliliters, you actually can get into a dissociative sedation, which is a little too much. But most often, they like to go the 200 to 400, so they get that euphoria feeling. But if they go a bit higher, they start losing motor control, having hallucinations, and can put themselves into a coma-like state. Nursing implications and patient educations. You want to monitor for respiratory depression and abuse. You want to monitor for a pulmonary infection. You don't want to stop their cough if they have an active pulmonary infection, because you want them to cough that medication. You want to cough that secretions up. You want to make sure that the patient doesn't become impaired with the amount that they are taking. You don't want to take it with grapefruit juice or orange juice, because it increases the concentration of dextromethorphan, which is what causes the toxicity as well as the euphoria. You want to be cautious with their ability to perform their activities of daily life after they take the medication. You want to make sure that they don't ingest alcohol or other CNS depressants. You want to make sure that they increase their fluids to help loosen anything up that they're coughing up, and make sure that they know they need to call the doctor if they have any shortness of breath, difficulty breathing, or chest tightness. You also have the potential to do narcotic antitussive. Narcotic antitussive primarily is going to be a codeine. It does work to suppress your cough reflex in the medulla. However, it's more sedating. It has a higher risk for respiratory depression and has a very high risk for abuse. So therefore, anytime you give anyone a narcotic a narcotic cough suppressant, you need to make sure you're monitoring for sedation, CNS depression, and safety, and some more safety, and make sure that they're not at risk for abusing the medication. Next drug is your guaifenesin or Robitussin. It is an expectorant. Expectorant loosens up your bronchial secretions, so it helps you cough up what you have to bring it up so it doesn't just sit in your lungs and breed more bacteria. It's used on colds, acute bronchitis, and influenza. Its contraindication really is only if you have an allergy to the medication. Your adverse effects are nothing significant. And side effects might be a little bit of nausea, vomiting, anorexia, but in general, it's well tolerated. You want to assess the patient's respiratory rate, rhythm, and characteristics. You want to listen for their lung sounds to see if they have any lung sounds that don't sound normal. You want to report to the doctor any findings that you have that are not within the plan of care. You want to make sure that the patient is increasing their fluids. They should be taking anywhere from 2 to 3 liters of fluids a day. And this will also help mobilize the secretions, loosen them up, and allow you to cough them up. You can notify the doctor if you have any shortness of breath or wheezing. Teach the patient to cough effectively. Teach the patient to cough even if they need to splint their incision from a GI surgery. And advise the patient to not drink or smoke alcohol. That is it for the drugs of the upper airway. Now we are moving to drugs of the lower airway. When we talk about drugs for the lower airway, we're talking about drugs that start down in your trachea, in your bronchial branches, that actually go all the way down into your alveoli where your gas exchange happens. We have patients who have COPD. COPD is chronic obstructive pulmonary disease. And these patients are probably our largest population of respiratory patients, as well as a large population that are hospitalized for acute respiratory deterioration. And it is a progressive disease. There's 4 categories of COPD. You have chronic bronchitis, bronchiolitis, emphysema, and asthma. All these patients will see a decreased respiratory function test and decreased respiratory system function in general. And your goal is to maximize their quality of life and maximize their respiratory function. COPD is an inflammatory disorder that leads to an airway obstruction. It has edema and constriction because you have so much edema going on. It's an inflammatory process, but there's no structural change. Chronic bronchitis is a progressive lung disease, often caused by smoking, chronic lung infections, or poor working environment. It is an inflammatory process as well as an excessive mucus secretion, causing airway obstructions, productive cough, hypercapnia, and hyperoxemia. Then you have bronchiolithiasis. That is going to be your abnormal dilation of your bronchi and bronchioles, so you're not getting good breakdown and you're not getting good gas exchange. Then you have emphysema. Emphysema is a progressive lung disease caused most often by smoking, atmospheric contaminants, or a lack of alpha 1 antitrypsin protein. It makes the alveoli large and then the walls get destroyed. So therefore you end up with what's called air trapping and decreased gas exchange. Bronchial asthma. Bronchial asthma happens with wheezing and difficulty breathing because the airways are getting inflamed and closing down. The lung tissue ends up getting necrotic due to lack of oxygenation, and then you can go into a respiratory crisis. Manage asthma. You're going to think of several different things that are going to have the management of asthma. You're going to have your adrenergics, which is your albuterol, which is your respiratory drug. You're going to have your steroids, but either oral or inhalation. Theophylline. You want to make sure the patient stays really hydrated. Oxygen is needed, and anticholinergics as needed. Your next drug are your sympathomiminic agents. This is your drug is going to be the cause because you need the dilation of the bronchioles. So it's for an acute condition such as acute anaphylaxis. You're going to give epinephrine with it as well as a respiratory inhaler, but you need to be cautious with your hypertension or in tachycardic patients. You can also use a beta 2 as well as albuterol. Your drug of choice is going to be albuterol or Preventolin. It is used for the bronchial dilation of an active lung disease. It also it basically causes the bronchial smooth muscle to relax so that it can open up and you can breathe much better. The only contraindications if you have an allergy to fluorocarbons, which is used in the inhaler. You want to be cautious with your cardiovascular disease and hyperthyroidism because it does cause hypertension sometimes and tachycardia. You need to be cautious with your diabetic patients because they have an increased risk for hyperglycemia and your seizure threshold is decreased. You want to be cautious. Your adverse reactions are going to be bronchial spasms, cardiac dysrhythmias, and angioedema. Your other side effects are going to be nervousness, tremors, headache, insomnia, and anxiety. Cardiovascular, you're going to have tachycardia, palpitations, and elevated blood pressure. And your other ones are going to have some nausea and vomiting. And the other is you need to be cautious that it doesn't trigger an asthma attack. Nursing implications. You want to perform a good quality respiratory and cardiovascular history before and after. You want to make sure that the breathing treatment worked and their airway is more patent. You want to make sure that you educate the patient the proper way to use his inhaler or her inhaler and to make sure that they're aware that this is a rescue drug. And when I talk about a rescue drug, that means that it is used in an emergency and it should not be used on a regular basis. If it's being used more than about 2 to 3 times a week, then the patient is using it too much and they need to go on a maintenance or find a better maintenance medication. Your next drug is an anticholinergic. The anticholinergic is tiotriptan or Spiriva. It is a first-line treatment for patients with chronic airway limitations or COPD. And basically they need that because of the diminished effect of acetylcholine on their respiratory system. The anticholinergics are one of the mainstay treatments in COPD. It is used only through some type of inhaler, whether it's aerosol or dry powder. And they can also use a bronchial dilator before the steroid or the cromolyn to open the airway. So you always use the airways to open up first, then you take your other medications. It's used for the management of COPD. It relaxes the smooth muscles of your bronchioles. The only contraindication are children, adolescents, and hypersensitivity. It does have some lactose in it, so if you have severe lactose intolerance, it is not recommended. You also need to be cautious if you're breastfeeding or have narrow angle glaucoma. Your life-threatening adverse effects are cardiac dysrhythmias, cardiac arrest, and paradoxal bronchial constriction. So it does the opposite. You can also have hyperglycemia and some dehydration, but the most common is going to be some insomnia, some restlessness, dizziness, some anticholinergic effects such as can't see, can't pee, can't spit, can't poop. And you can also cause some muscle cramping and peripheral edema. Implications in patient teaching. You want to monitor vital signs and monitor the use of the inhaler. It needs to be taken on a daily basis because it is a maintenance drug. And a maintenance drug is used on a regular basis so that you do not have to use your emergency drug, which is your albuterol. And you want to make sure the patient is using the inhaler properly. Your next drug is your anticholinergic that are inhaled. Your drug of choice for that is pyratrium bromide or Atrovent. Atrovent is used for the management of COPD, asthma, chronic bronchitis, and pulmonary emphysema. It is available in a meter dose inhaler or a nebulizer, and it does use your acetylcholine to help block the receptor site so it relaxes the bronchial smooth muscles. It's contraindicated if you have an atropine sensitivity or a soy-lectin hypersensitivity. You want to be cautious with your BPH, closed angle glaucoma, as well as a bladder obstruction. Your serious adverse effects is going to be bronchial spasms, angioedema, laryngospasms, and itching. Your most common is going to be a hoarse, irritated throat, and a few anticholinergic effects. If you're doing it nasally, you're going to have potential for epistaxis or nosebleed, headaches, rhinitis, nasal congestions, and rhinorrhea. Education and nursing implications. Make sure you always do a test spray before you use your inhaler. You want to make sure that you don't spray or send the mist out of the inhaler when you're not using it, because one, it's wasteful, and two, it is dangerous to get in your eyes. You want to make sure that the patient is taking this medication every day because it's a maintenance drug, not an acute drug. And that means they are feeling better because they are taking their medications. If they stop taking their medications, they do have potential for rebound bronchial constriction. Deliver all these inhalations. There are several different ways that we can deliver inhalations, medications. The first one and the most common one is the use of an MDI or a meter dosed inhaler. And how you want to start that, you want to shake the MDI well so you get it all mixed up. Then you're going to breathe out as much air as possible. And then you're going to hold your inhaler with the mouthpiece down. You're going to tilt your head back a little bit. You're going to hold the inhaler between your two fingers or place the inhaler between your loosely fingers, however you need to hold it. You're going to inhale one time, and as you start to take that long, deep breath, kind of like this, you're going to be pressing down on the inhaler so that you're bringing in the medication into your lungs. Once you get all the medication into your lungs, you need to hold your breath for 10 to 15 seconds so that the medication can work its way down into your lungs and doesn't just come flying back out of your mouth. And then if you have to do it again, you want to wait 1 minute and then repeat the exercise. You also have what's called a DPI, which is a dry powder inhaler. And basically you have very similar idea of how it's working. However, you're going to hold the mouthpiece between your lips. You're going to tilt your head back and place inhaler, press inhaler 1 time as you start to take a deep, slow breath. And that basically what you're going to be absorbing there then is a small pill that has been crushed or a powder that has been segregated out so that you can get your daily dosing. So you're going to be inhaling that powder, which can sometimes trigger a coughing attack. So you need to see how your patient responds. IV or orally, and when it's available, it's also a maintenance drug. It is not fast acting. That's why it's a great maintenance drug. It does have a long half-life, and it is an old drug. You don't see it quite so often, but it's an old but goodie. So when they still are using it, it works well. It is a bronchodilator, and it does stimulate the CNS and respiratory system, and it dilates your pulmonary vessels as well as your coronary vessels, and sometimes it can even cause diuresis. It relaxes the bronchial smooth muscles and pulmonary blood muscles, so it opens everything up. However, it does have your drug of choice is theophylline, and that's slow bid or Theodur, and it does have a very narrow therapeutic index, which is 10 to 20 micrograms per milliliter. And the problem with that is you have a high risk for toxicity if your serum levels go up above 20 micrograms per milliliter. So your theophylline is used to treat asthma, chronic bronchitis, emphysema, and neonatal apnea. Contraindications if you have status asthmaticus, pregnancy, or peptic ulcer disease. You want to be cautious if you have coronary artery disease, liver disease, renal disease, hypertension, coronary artery disease, congestive heart failure, as well as seizure disorders. Effects / side effects. Your most common are going to be a headache, insomnia, and irritability. You can get some palpitations and tachycardia. You can also get some nausea, diarrhea, vomiting. You can also have elevated liver function tests and urinary retention. But in general, it's handled pretty well. You only see the serious adverse effects and side effects when you're at a higher dosaging. If your serum theophylline level is less than 20, most adverse effects are not seen. If your serum theophylline level is between 20 and 25, most often you're just going to see your GI symptoms. And if it exceeds 30, that's when you're going to see your serious signs and symptoms such as hyperglycemia, hypotension, arrhythmias, seizures, brain damage, and even potentially death. So it's important to really monitor your theophylline levels so you do not get it above 20, where you'll see very few adverse effects. Nursing implication and patient education. You always want to do a baseline physical exam prior to giving the medication, and you really want to focus on the respiratory and the cardiovascular system. You do not want to smoke with it, but if you do need to assess for smoking, because cigarettes decrease the serum theophylline level, and often you will have to increase the dosage of a patient who is a smoker and does not plan on quitting while they are on theophylline. You also want to do a diet interview because theophylline is eliminated. Elimination is increased by low carbonate, high protein, and high charcoal beef. So basically, what does that mean? The elimination, it's not as effective for patients who have low carbonate and high protein diets. So the increases effect of the food also, increases effects happen with caffeine. So therefore, you want to monitor the amount of caffeine you drink, the risk of toxicity. You need to make sure that you monitor the serum theophylline levels. If you're going to administer it IV, your max IV rate is 20 milligrams per minute. Too fast can cause hypotension, bradycardia, dizziness, and flushing. And it can be eaten with a small amount of food or on an empty stomach. You never want to double up the dose because of increased risk for toxicity. You want to take it with a full glass of milk and a small amount of food to help with the GI distress. And you should not be ignoring the adverse effects and calling a physician because of the risk of toxicity is high. Drug is your lutein receptor blocking agent. That is your montelukast or singular. It is also a maintenance drug. It is used to reduce the inflammatory response of asthma triggered by allergic and environmental allergens. It can also be used for exercise-induced asthma. It is not for an acute attack. It is used as a maintenance or preventative or prophylaxis medication. Your only contraindication is an active acute asthma attack. You need to be cautious with your liver disease. You also be cautious if a patient has a psychological history that has some suicidal ideations. You need to be cautious with your patients who are on corticosteroids that are withdrawing from them, as well as your breastfeeding patients. Your life-threatening adverse effect is going to be anaphylaxis, suicidal and suicidal ideations. But the ones that are most common are going to be headache, drowsiness, dizziness, confusion, fever, and your basic normal GI stuff that helps with it. And again, remember, it's a maintenance drug, not for an acute fire, an acute respiratory system that's on fire from an asthma or COPD. Your nursing implications is you're going to always assess their respiratory status. You want to take the medication on an empty stomach if possible. And you want to maintain the medication and watch them closely if they're being weaned off of oral steroids for their respiratory problem. It's a maintenance medication, so you want to take it on a daily basis no matter how you are feeling. You want to watch for hepatic toxicity, which would be increased liver enzymes, jaundice, weakness, fatigue. You want to make sure that you contact the doctor if any other medications are being started. And it's best to take it in the evening or at night so that it works to its maximum benefits. Is your steroids. Glucocorticosteroids is used as an anti-inflammatory in the respiratory system. It's not a bronchodilator. It's an anti-inflammatory. Because when you have COPD or asthma, everything is inflamed. So you need that anti-inflammatory aspect of it. It's available in IV, PO, or inhalation. It will often take 1 to 4 weeks to reach the full effect of the medication. and is often used as during an acute exacerbation. It's not normally used as a maintenance drug. Sometimes low dosages can be used as a maintenance drug for patients with severe COPD that don't respond well to other treatments. It's contraindicated as before for any patient that has an active fungal infection or active infection in the respiratory system. It is available orally as most often prednisone. It can also be used as an inhalation, and that would be flunocylide or Aerobid, and that would be via a MDI or a aerosol medication. Your most serious adverse effect is your hypothalamus pituitary axis suppression, and that most often happens if you're taking the oral medication, not so much if you're taking the inhalation medication. The other adverse effects or side effects are going to be sore throat, hoarseness, coughing, dry mouth, some fungal irritation, candidiasis. And if you're taking oral in children, they can have some delayed growth. So it's really important that they monitor for all these side effects in adults and children. Implications are going to be, you're going to be looking for active lung infections prior to administration. You also are going to be looking for if you're going to be determining whether or not why the patient is getting the medication. If they're doing it for a chronic maintenance drug, they need to take it on a daily basis. If it's a short term for like pneumonia or bronchitis, they need to follow the doctor's instructions so that they are taking it appropriately. If they're taking it as an oral, they need to make sure they taper it before they stop it to prevent adrenal insufficiency. They also have to make sure that they're wearing a medical alert bracelet if they're taking it orally, so that people are aware when they get to the hospital. They should avoid smoking because it decreases the efficacy of the medication. You make sure that you're using the inhaler properly. It is a maintenance inhaler, not an acute inhaler. The other key thing is if they're doing it as an inhaler, they must rinse their mouth out completely so that they don't develop thrush and candidiasis in their mouth. And that way that they don't get that red, white, splotchy stuff in their mouth. You also have to monitor for HPA suppression, which most of the time only happens with oral medication versus the inhalation. Your next medication are your mast cell stabilizers. Your mast cell stabilizers is going to be your chromium sodium or nasocrom. It is used as a prophylaxis treatment for bronchial asthma. It can be a daily treatment or an as-needed treatment. It is used to treat allergic disorders and bronchial asthma. It's used to prevent the release of histamines, which creates that allergic response. It has zero bronchial dilator activity. It only works with your histamine release. Contraindication is if you have an acute attack or if you have coronary artery disease or dysrhythmias. You do want to be cautious with your patients who have lactose intolerance. Adverse effects are going to be bronchospasm or anaphylaxis, which is very rare, but your most common is throat irritation because it's a dry, itchy throat. You also it also has a kind of bitter taste to it. If you're taking it as an oral, it has lactose in it, so it can cause bloating and cramping and flatulence if the patient is lactose intolerant. implications. You want to monitor for the respiratory system as well as the cardiovascular system. You want to monitor patients with lactose intolerant for GI distress. And you want to be sure that you use the correct ordered method to take the medication, whether it's inhalation, nebulizer, or a dry powder inhalation. You want to make sure that it is used as it is ordered, whether it's prophylaxis or daily. And you don't want to, if you're doing it daily for asthma, severe asthma, you want to make sure you taper it off and you don't just stop it abruptly. Next drug is your mucolytics. Your mucolytics are your medications that helps break up the mucus in your chest so it's easier to cough it out. It liquefies and loosens thick mucus secretions. And if you're using bronchodilators, should be given first before the mucolytics so that you open up the airway and then take the mucolytics. It also can be used in an acetaminophen or Tylenol overdose to help neutralize the negative effects on the liver. It also can be used with contrast dyes to help prevent renal toxicity. It's used for Tylenol overdose, prevention of contrast-induced renal complications receiving contrast agents. It's also used to liquefy thick, tenacious secretions. It can be given PO, IV, or a nebulizer in the lung for lung disorders. When it's given as a nebulizer, it smells something fierce. So you do have to warn the patient about that. Your only contraindication is hypersensitivity. Your precautions are going to be pregnancy, respiratory compromise, asthma. You need to be cautious if you're administering IV for patients who have liver disease. And you need to be careful with patients who have esophageal varices or peptic ulcers because it tastes so bad it can induce vomiting. Effects, there are bronchial spasm and anaphylaxis. Your most common adverse effect is an extremely unpleasant odor during the administration. It basically smells like sulfur, and it's a terrible rotten egg smell. You can also have some nausea, vomiting, and some rhinorrhea. But in general, it's well tolerated. And you do not want to spill this on you because when you spill it on you, you end up wearing it for the rest of the day, and nobody wants to hang out with you because you smell so badly. Nursing implication, you want to make sure that they are taking it appropriately. You want to be careful if you're giving it to someone who has any respiratory compromise, because sometimes it makes it difficult for them to cough it up, and then now they just have more volume down there. You want to wash the patient's hands and face if you're administering it via a nebulizer because their face will be stinky and smelly and sticky. You want to make sure that you rinse out your mouth or brush your teeth after the treatment to help eliminate that lovely taste. It also helps to do what we call chest physiotherapy, which is where you bang on the chest to loosen up those secretions so they can come out easier and you have less chance to end up with an infection. And if you're giving oral acetylcysteine or mucimist, you need to mask the taste with something such as diet soda or juice or something because of the fact that it is awful tasting. If you're also giving it as an antidote for acetaminophen overdose, it needs to be given within 24 hours post-ingestion, but ideally within 8 hours of post-ingestion of the acetaminophen. And patient education, they need to make sure they know how to use the inhaler or the nebulizer, teach the physiotherapy to break up the mucus if necessary, and contact the doctor if there's any respiratory distress, and make sure that they don't take any other medications that they haven't discussed with their healthcare provider. And that is it for your respiratory lecture.